Welcome everyone to this episode of Office Hours. I'm Stuart Newsom, your host. And today we're coming to you live from the Infinix GTM Growth Summit here in Denver. First time you've ever done anything like this, so bear with us as we work through it. But we're going to talk today about a new AI agent for medical necessity. So I'm really excited about this. Joining me is Navaneeth Nair, our Chief Product Officer here at Infinix, is going to do a deep dive into what this is all about. Navaneeth, always good to see you.
Always good to see you, Stuart.
Always good to have you on as well. So, how you doing today?
It's a beautiful day.
Yes.
We've been energized by our team here. And then, of course, new solutions always makes us happy.
Yes. We've been highly anticipating this. So, this is an official announcement of our medical necessity AI agent. So, it's going to be a good conversation, because medical necessity has always been friction within the revenue cycle. It causes schedule delays. It obviously causes manual rework from denials, the whole appeals process, all of that. So during this session, we're actually going to do a deep dive into those problems. What is Infinix doing to solve those problems? And incorporating AI without negating the human specialist, the human in the loop, if you will. So with that, I want to remind everyone here in the audience, we do have a live audience with us today, to ask questions. We're going to have a Q&A at the end, and we'll have, for those online, you can just put your Q&A in the Q&A box in Zoom. And also welcome comments. So if anybody's got any comments that you want to share, we always welcome those as well. So with that, Navaneeth, you ready to dive in?
Go right ahead.
All right, so we're going to buckle up here. So when we talk about medical necessity as a workflow problem, where do teams feel the most friction today?
I think there are a few different places where medical necessity causes friction. I think just getting the right amount of information to understand medical necessity is a challenge. Because whenever I think physicians are creating orders for especially specialty procedures, they are really not thinking about all the documentation. That they are thinking from a patient-centric perspective. They're not thinking from an administrative perspective.
Right.
But getting that documentation is very critical. So that's kind of one of the first areas of friction that we see most of our customers have. The other area of friction, which actually has increased quite a bit over the last, I want to say, 2 years, is the rapid change in policies that we are seeing from the payers. We are used to having payers change policies on an annual basis. We are seeing quarterly or even more, I would say, rapid changes to these policies. Either it's coding related guidelines or prior auth related guidelines. So I think that's the other area of friction, because I think people understand some of these guidelines, they build some tribal knowledge around it, but now the policies changed and they don't know where to go find it, how to find it. So it's not easy to have the right information available for you to do that work. So I would say those are the two big, just having the right documentation available and knowing which policies to look at.
Right. Understanding where the regulations are is
Correct.
one battle, because not all payers play nice and publish their policies, right? So it's
Yeah, I think even though they publish it, it's just not easy with the number of
Right.
payers and plans and the plan level kind of exceptions associated with some of these things. It's a very complex process.
Yeah, exactly. So next question is, well, what made this the right time to introduce, an AI agent solution for something like medical necessity? And how do you define the agent's role? Because I think that comes up a lot in conversations that we have with clients and prospects. What is this agent going to do? What it's not going to do? And are there any guardrails to make sure it behaves appropriately?
I think great question. I think I've been looking at the problem for 10 plus years. And the reason the problem is very challenging, and the reason it has always been something that is the domain of experts, is that if you look at the clinical document or clinical documentation that providers and physicians create, they're essentially highly unstructured and subjective documents. Now you have to interpret a very subjective document. At the same time, the guidelines and the policies themselves are somewhat ambiguous and subjective. So you really need expertise to be able to actually understand what the physician is trying to do and match that to the guideline.
All right.
And AI, for the longest period, even with all the work that was done in natural language processing and other capabilities, had a tough time kind of separating from structural language to semantic language to understanding things like negation.
Mhm.
All of these were problems that essentially did not lend itself. But over the last, I want to say, year and a half, 2 years, what we have seen is that as AI grows, and most of you recognize it as generative AI, it is actually has now the capability to reason.
Mhm.
So now when we are able to actually train it with our domain expertise, it actually better understands the information. So this is I would say the right time for agents to start kind of becoming an integral piece of what we do. And how do these agents work, right? I think the way we think about this is that if you have the right amount of information available from the physician documentation, the agent's job is to find the right policy and guideline.
Mhm.
So it actually has a domain repository of all the policies. Its goal is to then actually match it and identify whether we meet coverage or not from a medical necessity perspective. But just to be clear, the agent is actually acting in partnership with the front office team. The agent's role is not to say this does not mean we're not going to schedule the patient. The agent's role is to actually guide the scheduling and the front office team about the possibility that there is a gap. And what that does is it allows the front office teams to understand what their next step needs to be.
Right.
Whether they need to reach out back to the patient, do they reach out back to the physician, and what step do they take rather than just scheduling the patient. So
Mhm.
it's actually, I would say, a co-pilot more in that sense. It's actually somebody who supports you
Yeah,
in,
kind of like a
in your
guide.
in your process.
Right, right, exactly. So you talk about cases, which case types are best suited for AI-driven reviews, and which scenarios still require that human clinical and utilization management expertise? So what's the balance between the AI and the human specialists
Yeah,
involved?
I think we continue to learn that. We're in early stage of understanding that construct. What we're seeing is that policies where there is high frequency of the same procedure being performed, the pattern recognition becomes much stronger. But there is ambiguity in either the policy or ambiguity either in the procedure that is being performed or the diagnosis that is being suggested. Uh, what the AI is built today is essentially to be conservative, in the sense that if it actually does not feel that it has all the information necessary, then its goal is to really actually hand off to the human specialist and say, hey, here is why I'm handing off to you. But again, the handoff is not saying, hey, you go do the work. It's actually doing all the work and saying, hey, I looked at it. I could not find all these pieces. Can you help me here? Right?
Mhm.
So in that way, the AI is never kind of failing. It's more about saying, hey, I don't have all the information. You may need to help me here.
Right, right.
That's essentially how to think about the process.
Right, right. It's like gathering the information to know what decisions need to be made. It's not actually making the decision itself. It's just grouping this information together so the users can make a more informed decision.
Correct.
Right.
Correct.
Gotcha. So if medical necessity is addressed earlier, because I'm a big proponent of denial prevention, and the earlier that you can get this done earlier in the process, the better. But which downstream metrics, would you be looking for that would be improved the most? Is it scheduling throughput, authorization turnaround? Just pick one, or maybe pick several.
All of the above.
Yes.
I wanted to check that box.
Yeah.
And we've talked to so many of our existing customers about this, right? And what's interesting is that uh, the challenges lie in different parts of the organization, right? If you have a large imaging center, you are not the physician. The physician is an outside physician who's sending you documentation.
Mhm.
But you have to make sure that you actually can get that patient scheduled on time.
Yeah.
Because if you do not schedule that patient, the patient is going somewhere else.
Mhm.
So in that scenario, the challenge lies in the front office, right? Because you're actually trying to figure out that you want to make sure that that patient comes through the door. But if you don't have the right information, you'll have a denial, you lose dollars in the back
Right.
end. So the goal is, and in that case, make sure that the front office has the most information. In some cases, our customers have said, hey, we want to do this mid-cycle. What that means is, oh, we have done it in the front office, or some reason we can't do it in the front office because we need to really have them come through. It's a hospital, it's an inpatient procedure.
Mhm.
They're already in there, the procedure is being performed. then pre-claim, you want to at least make sure that you have all the information necessary before you send the claim out.
Right.
The goal is ultimately not to get a denial, right?
Mhm.
Now, of course, if it leaks it into a denial that has to be dealt during AR, of course, it helps us understand what information we should provide for appeal.
Mhm.
But the goal is never to get there. The goal
Right.
is always to help the patient get through the door if it's like an ambulatory situation. But in other settings, it's also to ensure the documentation is correct before you send it out
Right.
to the payer. Now, what we're seeing with many payers is infrequent bills are increasing, and most of the folks who understand that are seeing that. Having this reviewed earlier by an AI agent allows you to have the information. Many of the payers are now allowing you to actually attach documentation with your claims electronically. So you can actually preemptively attach the right amount of
Right.
documentation so you don't get an info required denial, right? Because that's another thing we are seeing with
Yeah.
the payers, that there is a lot of info required denials coming.
Yes. Yes. Any means necessary to pause and delay that payment.
Correct.
So
Correct.
absolutely.
And just to say it out loud, payers are using AI on the other side, just to be clear, because they are scaling this at. So
Yes.
what that in the past, if they had to have an expert do this, now they actually have the ability to apply AI on the other side, which means
Right.
more denials.
Exactly. They've always had the data, and they've always had a means of crunching that data. Now they can crunch it just at a far
Correct.
superior accelerated rate. It's kind of scary. So providers have to counter that. Look at it as counter with warfare, so to speak. You're combating.
Yeah, I don't want to use.
I know exactly. Exactly. Don't go there. So,
Given real wars in the world, I want to
exactly.
be careful
Exactly.
about that. But I
Exactly.
agree with you.
Yeah.
It is a conflict that we are trying to resolve, and our goal is essentially to help our customers have the right amount of information so they have less friction in the
Right.
reimbursement, as you
Right.
said.
Right. So let's say it's a few months, after go live, and someone's adopted the solution. What does success look like in the real world, and what should clients be tracking, and what is a realistic timeline to the impact that the AI agent medical necessity is going to have on them?
Yeah, so I think the first thing, and with the early adopter customers that we've been working with, the first thing is that many of these teams either have dedicated clinical or clinically capable staff just doing this, or in some cases they do not have the staff and they expect the front office to have the expertise to do this. What this does is really relieve the burden of the front office or of teams that actually have to do this. Now they know that they can actually send it to the AI. Now, if the AI flags it as something that needs attention, that's the only things that they should look at. Others, they should feel very confident moving forward. So what it does is reduces that front office burden. In some of the teams that we are working with, they have dedicated clinical teams. And this becomes now an agent that works as part of their teams. Some of these teams just don't have the bandwidth to expand. Finding clinically or coding specialists who actually can work in the front office to work through medical necessity is a challenge.
Right.
So now you can actually augment those teams. And what augmenting those teams are going to do is, and most of the times we think of it as, okay, we will reduce the number of people who we need in this process. That's not how most of our customers are thinking. They're saying, hey, we can do more. We have been actually not doing a lot of it because we just don't have the bandwidth to do it. Now we have the ability to apply AI into it, allows us to now actually do procedures that in the past we would have just let through and said, hey, we'll deal with it when we get a denial.
Right.
Now they say, no, let's actually look at it in the front because AI can scale this for us.
Right. Exactly. Exactly. And that's been kind of I don't want to say old school. That's been the way it's been done. Is the denials, medical necessities handled at the denial level when it's way after the fact. And if you can prevent it ahead of time, then you're actually saving money. You're being much more efficient, where you don't have to touch that claim again. Because it's like $8 to get a claim out.
Just
Anyway,
for a touch.
for the first touch.
Yeah.
And it's typically $25, and I'm being conservative, to rework a claim. So
Absolutely.
and the mindset was, well, we'll just let it go through, and then we'll handle the medical necessity when it becomes a denial.
Yeah. So the lagging indicator, of course, is reduction in denial. But the other thing that, especially with our ambulatory customers, we're trying to track is how many more schedules were they able to get through that in the past they would have actually had a challenge in getting through because they could not identify if this patient has all the information. So they decided not to schedule that patient.
Right.
The last I would say is that I would say just better Medicare reimbursements, because I think EBNs are becoming critical, and uh, for Medicare procedures, it's actually difficult to understand. Most of the ABN solutions currently out there in the market are rules-based, as
Yep.
you're aware, but the rules are also pretty tricky. So we see a lot fall through that these rules-based systems make mistakes on that the AI is able to catch.
Right. And the rules is based on the information set up
Yeah.
in the rules at the time, and if they get outdated, then you have to rely on changing the rules to get it
Yeah,
right.
we would just recently had a scenario where we were testing with one of our customers, and we found one of the rules said it should be covered, but when we looked at it, it said not covered, because the AI was able to identify that you could have covered this, but the diagnosis that you had coded, the physician had coded, was not covered by Medicare,
yeah.
right? But they could not recognize the fact that that diagnosis was not coded, because the general tendency is that this is covered, so Medicare will cover for it.
Right.
So these are things that the AI is able to surface, where people are like amazed that, oh, wait a minute, I can step back and look at this and now say, wait a minute, I had not thought about that part.
Yeah, that's awesome. That's awesome. Well, we are going to go to a Q&A with our Q&A section. Again, if you have a question, either here in the audience as well as any questions online, we'll address the online ones. Are there any online? None at all right now? Okay, so any questions in the audience? Okay.
So I wanted to know, is the AI going to be done like on the front end to do like a claim cleanup?
Yeah, so it's going to be done in the front end even before the claim.
Okay.
So the assumption is when an order comes in, whether that is like an in-house order or an external order that's coming in, you have all the information that is necessary. You schedule the patient, you actually run this as part of your front office processes. Because a lot of prior authorization, as you know, is run as part of the front office, but a lot of medical necessity detail checks, unless you have a clinical team, you're not doing it. You're letting it through and assuming that it'll meet medical necessity, or unless you have knowledge, you actually evaluate it, or you have some kind of rules-based systems. So the goal is to actually do it in the front of the life cycle. So by the time you are actually seeing the patient, you actually are fairly comfortable that what the physician has ordered essentially will meet medical necessity criteria.
So what, excuse me, what happens to us in a lot of cases is that we have coders that are actually into the EHR, the hospital system, whatnot, and they submit the diagnosis that they find, and then we get it back that it's not medically necessary. So then it's going to the AR because it's been denied.
Correct.
So if we could have something that would, avoid
It-
it from going to that AR team.
Absolutely. So our preference, and again, it depends on, as I said, there are two places we would want to run it. We want to run it, just find it upfront that the diagnosis is not coded correctly. So the diagnosis gets coded correctly. So by the time it gets into the system, the coder is not having to pick a diagnosis that he's guessing from the documentation, right? That's actually the preferred approach, because what the AI does is it actually comes back and says this diagnosis does not meet, right? It does not suggest today, because we don't want to be in the space of suggesting what diagnosis would work, but it can identify which does not work. But let's assume that is already done and we don't control that, because the physician has already said what he needs to say. They've already gone ahead with the service being performed. Then we would run this pre-claim as part of the coding process or post-coding to ensure that what is coded is going to meet medical necessity. Otherwise, loop back to the coder and say, hey, here are the rationale of what is missing. Either the diagnosis needs to be corrected, or in some cases, we need additional documentation back from the physician to ensure that if we do get a denial, we can actually counter that with an appeal. Or more importantly, as I was saying earlier, now we can actually do attachments earlier on. A lot of payers are suggesting you actually do electronic attachments ahead of time. We can actually attach the right information and submit it to the claim. So those are two possible spaces.
Yes, very cool.
There's one question. Yeah, another question over here. Yep.
What does implementation typically require inside an existing scheduling or patient access workflow? So integrations, data inputs, workflow changes, and internal stakeholders, what does that look like?
Yeah, so I think what we've been doing is working with the patient access teams, and for an early onset solution right now, our goal is to reduce as much friction as possible. Now we have the ability to integrate with the EMR using HL7, other standard interfaces to actually accept that as a request. But with a lot of customers, we actually, as Infinix, because we also bring the domain expertise and the services teams together, we have the ability to work with you. Many of our customers are actually giving us a very dedicated work list in the EMR and saying, hey, here is a work list where we created a filter of everything we want to run through medical necessity. Can you just run it through the tool? In some cases, we are integrating with the tool and getting it. In some cases, we are actually having our teams go and grab that information, run it against our tool, and put the results back in, right? So our goal is to reduce the friction to get started and see value generated. Integration is our preferred approach at the end of the day, but the goal is to actually see operational value as quickly as possible. So we have a few different ways to do it, including kind of manual bulk upload runs of all the cases that need medical necessity reviews.
All right. Another question?
Yeah, so this kind of adds on to that, but I'm just thinking about the change management that might be required if you have, existing manual processes. What what would you say is the first step to kind of either implementing a new solution or just solving this just generally, operationally?
Yeah, so change management, right? The word that we're all afraid of, so to speak. What has pleasantly surprised me about the solution is that because the solution is so powerful, most of the people I've talked to, whether those are clinicians, actual physicians who are actually doing this work, or coders who actually do the work, they're just blown away by what it can do, right? So what that does is when you can actually show results that actually it exceeds people's expectations, people actually gravitate towards it much faster. So I've
Absolutely.
actually had less challenges getting somebody to say, hey, we should do this in the solution than any of the other RCM solutions we talk about, because of the fact that it exceeds their expectations. But that doesn't mean there isn't change management. I think the big thing is to really, get them comfortable that it's going to do what it's going to do accurately. So we do a lot of testing with some of our customers. Early stage pilot is how we kind of present it. Our customers work with us. We give them a 60-day window to actually early stage pilot with some of the power users, so to speak. And once we are comfortable that it's actually working with the power users, then actually we built out a workflow and a life cycle that works in parallel with them. So in the example I gave you earlier, if there is a work list, and instead of them going into the EMR and having to go through each one of them in the work list, now they're actually in our solution looking only at the ones that are exceptions or not covered and identifying the ones and then doing the exception handling, right? So that way, now they feel that they don't have to go through every line item, they just have to go through the ones that are being solved, right? So we're finding that the general sense of adoption is much better because they're seeing immediate value with it.
Yeah, that's just such more efficient, just where they could focus on those exceptions and those complexities that involved and not just the mundane. So that's
Yeah, one of the senior coders I was talking to in one of our customers who does this today, and she said, I literally go through a case for 25 minutes just to say it is fine, right? So
that's awesome.
in her mind, that is not good value because it is going through the door. I mean, though it's value because if you had not checked it, you would not know. But now that the AI agent is doing the ones that can go through, she's like, I really get to work on the ones that are not going to go through. Pick up the phone, talk to the physician and say, hey, here is where your documentation is falling through, which we need help with, right? So that actually kind of made the coder feel that they are valued more with respect to the work they're doing because they're really finding the real problems, not having to deal with every case where after 20 or 30 minutes, they realize that it's going to go through.
Yeah, just helps with their bandwidth, and that's
Absolutely.
always a plus. So any other questions online? Any other questions with the audience? All right. Well, that's going to wrap up this session of Office Hours. I want to thank you, Navaneeth, as usual.
As
Appreciate you as
Thank you.
always. We'll have some more with him in the next coming months or so. But also want to thank everyone in the
You
audience.
just sign me up for new things.
Yeah, just sign you up for new things, and then I'll tell you about it later, right? So just thank everybody here live, and thank everyone online for joining us. I want to encourage you to listen to our podcast. We will repurpose this for our podcast, Revenue Cycle Optimize, and also visit our website at Infinx.com for more articles, use cases, and insights into solutions. And if you want to have a conversation with us, just go out there and contact us there. We'll be happy to talk to you. So we'll see everyone next time on Office Hours.